Hello guys, welcome back. I hope you all are doing absolutely fine. And in these tough times, I hope you and your family members are absolutely safe as well. So we'll be continuing with our surgery basic series, Know Your Electrolytes, with our second electrolyte, a very important electrolyte in our body, which is potassium. We'll try to understand what will happen in our body when there is a condition which is hypokalemia, wherein there is a decrease of potassium level in our body, and hyperkalemia when there is an increase in the potassium level as well. So first of all we'll be trying to cover the hypokalemia part, and then we'll be moving to hyperkalemia, right? So let us begin. Hypokalemia, uh, first point is serum potassium levels in hypokalemia. Hypokalemia, serum potassium level less than 3.5 millimole per liter, wherein in sodium it was 135 millimole per liter. Second is the cause of hypokalemia, intercellular shift, which leads to metabolic alkalosis, insulin beta 2 receptor agonist, alpha blocker, amphotericillin B, increased loss, hyperaldosteronism, Cushing's syndrome. So what happens in Cushing's syndrome is there is hypercortisolism. The exposure to increased cortisol level for a long time leads to Cushing's syndrome. Barter's syndrome, which is a rare genetic disorder of kidney wherein the function of kidney are impaired, wherein the ability to absorb salt is lost. CAH, congenital adrenal hypoplasia. DKA, diabetes ketoacidosis, and diuretics. Clinical features of hypokalemia include fatigue, myalgia, episodic muscular weakness, hypotonia, paralytic ileus, abdominal distension, hypoventilation, more negative resting memory potential, and decreased DTR, deep tendon reflex, and metabolic alkalosis. There are some ECG changes also which happens when there is hypokalemia, which includes flattening or inversion of the T wave and prominent U wave, ST depression, and prolonged QU interval. Some of the basic treatment for hypokalemia could include oral Potclaw, KCl. If IV potassium has to be given, rate should be less than 20 millimole per hour and not greater than 24 millimole per day. And ECG monitoring is must in all the cases of hypokalemia and hyperkalemia respectively. So with this we have tried to cover hypokalemia. Now let us see what happens when there is a condition of hyperkalemia in our body. First of all, the levels of in the serum potassium level will be above 5.5 millimole per liter, and in hyponatremia it was above 145 millimole per liter. So like this we can easily guess the two and try to remember the two ranges of the same: hypernatremia and hyperkalemia. Hyperkalemia less above 5.5 millimole per liter. Causes of hyperkalemia: renal failure, acute plus chronic. Always impaired There is always impaired reabsorption of sodium, hypoaldosteronism, pentamidine, trimethoprim, ACE inhibitors, heparin. Injury, sepsis, and hemolysis could also lead to hyperkalemia. Clinical features includes partial depolarization of the membrane, results in weakness, flaccid paralysis, hypoventilation, arrhythmias, metabolic acidosis. ECG changes in the hyperkalemia state are tall and peak tentacular T wave is noticed. It is the earliest change in the severe hyperkalemia. Prolonged PR interval and QRS sine wave pattern, ventricular fibrillation plus anisystole is seen. So this is just the ECG demonstration which I have made. In the treatment for hyperkalemia could include calcium gluconate, insulin with dextrose, IV NaHCO3 sodium bicarbonate for severe cases. Okay guys, so with this we have seen the different types of conditions which occur, some normal ranges of sodium and potassium, the respective states of hypokalemia and hyperkalemia as well. So with this I end this video, and if you do like this video, please do like it and share it with your friends, and do subscribe to my channel. It will motivate me to make more and more such videos for you all and help everyone around, right? So with that said, thank you very much. Stay safe.